Where do you fit in? What is your value? Maybe you issue pathology reports every day. Well, perhaps I can get someone else to issue that report and do it cheaper. We need to know the value of what we bring to medicine. There's an explosion now of scientific knowledge and biotechnology that needs to be applied clinically. We know how to do that. That's part of our value. Someone might say that all we bring to the table is just a commodity. Maybe somebody else can pack up the tubes and specimens, ship them somewhere in the box overnight, and have words and numbers magically show up in the morning. Sure, that can happen. But someone has to interpret and apply that science into medicine. The patient cannot, and increasingly, the providers cannot either. That's part of our value. The challenges we face today in healthcare may be new. The tools we use to make our diagnoses, molecular diagnostics, immunology, immunohistochemistry, flow cytometry, may also be new. But precision, accuracy, and clinical relevance endure. That's part of our value. That is the conversation that I want us, all of us, to have over the next 2 years. We are seeing dramatic changes right now, not only in technology, but also among providers and patients as well. New molecular techniques, imaging modalities, and methods of specimen acquisition continue to be added to our toolbox every day. But medicine is getting more and more technical and more molecular. While there are more patients, the caregivers at the front line have less training. And primary care doctors have often only 8 minutes with a patient before having to move on to the next one. They don't have time for thoughtful analysis. Taken together, this translates into greater complexity, increased volume, and fewer credentials at the bedside. That's a mismatch. And there's room for us in that mismatch. The explosion of scientific knowledge and biotechnology needs to be translated for an expansion of providers. We know how to do that. We speak both languages. That's our niche. We may not like everything about the way our healthcare system is evolving. But you know what? That doesn't really matter. 20 years from now, all that will have mattered is how we chose to respond. This week, we are presenting learning topics around the theme, advancing diagnostic medicine. And we are making choices right now about how diagnostic medicine will be practiced in the future. So starting tonight and continuing on over the next 2 years, let's talk about those choices and how we can respond. So to begin the conversation, I'd like to start with 3 premises. 1, the healthcare system is in a state of flux and will continue to be so for some time. Changes will continue. 2, evolution of healthcare policy by itself is neither good nor bad, but it is inevitable. And 3, patient-centered thinking is the foundation of healthcare reform. From there, as the saying goes, we can let constraints unlock our creativity. In Massachusetts, we have had more than 8 years of experience with mandated, coordinated care. And we're getting busy. There's simply not enough primary care providers to take care of everyone with insurance. Without more people to do much of what physicians can do, the promise of the Affordable Care Act will remain unfulfilled. Fundamental shifts signal a greater emphasis on population health. We have much to contribute in this realm. But how can we take care of so many new patients without compromising quality or growing growth? So let's step back for a minute and consider what all diagnostic fields have in common. whether pathology, laboratory medicine, nuclear medicine, or radiology. Something comes in the front door. We do something scientific to it, we analyze the output, we make a clinical interpretation, and we report our findings to a provider who applies them in patient care. A block of tissue or a tube of blood can be seen as a dense data repository. A slide made from that tissue leads to images that focus the diagnosis and informs you of how that structure came to be. An assay on that blood yields molecular biomarkers that suggest a targeted treatment. Our role is to extract the data from that repository, integrate it into the clinical picture, and translate the result for clinical action. To that end, we will rely more and more upon outcomes-based diagnostics and tools from all available sources. Our work is becoming more quantitative, more digital, and more integrated. Before coming to Bay State in 2001, I practiced clinical pathology and transfusion medicine at the University of Alabama in Birmingham. I also served for 8 years as the chief of pathology and laboratory medicine at the Birmingham VA. In my last 5 years there, I also oversaw laboratory radiology, nuclear medicine, and radiology for the VA Integrated Service Network across the Southeast United States. So why am I telling you all this? Because I learned a lot at UAB and the VA about medicine and service networks. I got to see a different side of medicine. We call our service line DMSL, Diagnostic Medicine Service Line. People may not know what pathology is, but they know what a diagnosis is. When I came to Bay State as chair of the Department of Pathology, we added a subtitle to our department name, Diagnostic Medicine Services. So how does this relate to the big picture? I see healthcare reform as the end of primary care as we have known it. The current model cannot fulfill its promises, and there are not enough primary care providers out there. At the same time, medicine is increasingly scientific. We have old tools, we have plenty of new tools, but we cannot afford to be defined by any of them. We simply cannot report only what we find. We have to translate it for those at the bedside. If you think about it, most physicians care far more about how to treat an infection than what caused it. So if we issue a report like this one, and it says somewhere up there, no cell scene, 2+ gram-positive cocci, and tack on some inkhorn, latinate, genus, and species, guess what? Nobody may understand. But if we add in MRSA should be considered clinically resistant to all beta-lactams and order the list by susceptibility, bingo, that's what they want. Molecular diagnostics can reveal the presence of a gene, but cannot tell us whether a given drug actually gets inside the cell to function. Identification is not translation, and providers need both clinical interpretation and guidance for next steps, and increasingly that is the handoff. More patients are learning how to access their own records every day. Yet much of the content is not clear to them. I believe that we should think about what we communicate in our reports. We could reduce anxiety by using less technical terms. We could simplify how we report our results to make them understandable to their audience. I see patients every day that I'm on service. Sometimes those patients are friends and colleagues. More than once, a surgeon has come into my office deeply shaken, holding his pathology report that shows our diagnosis of his prostate cancer. I gotta have this out, he says, but I'm worried about the surgical complications. All right, well, let's take a look at your report, I say. This might be slow growing, this might be something to watch for a while. He responds, you don't understand, I gotta have it out. Well, actually, you don't. There might be some options. But he doesn't hear me. And he says, you don't understand. I can't sleep knowing it's in there. Oh, I can see that. That's understandable, I respond. But you do realize you talk about having surgery to treat anxiety. As pathologists, we can help demystify things that need not be frightening. It is one of our traditional roles. And at 8 o'clock tomorrow morning, a scientific plenary session on the active surveillance of prostate cancer will explore this topic. I recommend it. Medical care today is more and more about chronic disease. Patients learn to live with conditions that would once have killed them. We have antibiotics, we have some chemotherapy regimens, but beyond that, there are not that many cures in medicine. If you have a bladder infection and you take the correct antibiotic, it's gone. But if you have diabetes, that's not cured. That's a lifelong management problem. Same for congestive heart failure. Even if chronic kidney disease resolves with a transplant, you're left managing medically rejection. If you think about it, over the last 20 years or so, we have converted 2 to 3 year death sentences into multi-decade management problems. We have effectively converted acute illness into chronic disease. And we're surprised that the cost of healthcare has gone up. Healthcare is getting more expensive because we're getting more healthcare and we are living longer. We don't know where we're overtreating, but we do know that patients are not dead ones. We can help our colleagues figure out how to talk to patients about the disease processes, how to explain and discuss what they are dealing with and what exactly can or should be done. It may be our place to point out that we may be turning a problem into a management problem. If so, that's fine. Let's just admit that and figure out how to manage it. You know, I often talk to patients and the community who are fascinated by this black box of laboratory science of ours. They know that somebody takes a tube of blood or takes a biopsy and it goes off somewhere. They don't know where. But once I explain it to them and unbox that black box of laboratory medicine, laboratory science, I often get asked if I will become their primary care doctor. There's a real hunger out there to know what's going on inside their own bodies, and we can help them make sense of it all. I believe that our future is more molecular and medicine will be more laboratory driven than ever before. I think there will come a day when we diagnose malignancy knowing full well there will not be follow-up biopsies. We'll use molecular tests to monitor the patient and identify what is actionable, whether it's soluble HER2 or circulating tumor cells. We will be spending more time with more readily accessible specimens to monitor serial testing of cancer than making primary diagnoses. In anatomic pathology, the morphology is only as useful as the information we glean from it. Will anatomic pathology come to be seen as only the first step? Are we prepared for a cultural shift to come when we begin to see more serial liquid biopsies than surgical biopsies? When we have more specimens obtained by less invasive means to monitor chronic disease? When we have many more opportunities to work with many more colleagues more closely in a variety of new venues? Folks, medicine is now a team sport, and we are moving steadily towards serial collaboration. That's one reason we revised our department name to include diagnostic medicine services. We wanted more people to understand what we did. Is HPV testing virology, microbiology, molecular cytology? It doesn't matter. It's diagnostic, it's us. Already, there is an explosion of mid-level providers, like nurse practitioners and physician assistants. People with 2 years of training and little added experience who can do much, but not all of what a primary care doctor can do. A good physician can manage maybe 95 to 98% of what they see. Maybe a mid-level can handle 70%. But those who can only handle 70% need to know what 30% they cannot handle. Think about it. More providers with less experience treating more patients with more complex problems. We need to find ways to help them understand what they are seeing. We need to be aware that our jargon can be baffling to newcomers. We need to train people to know what they don't know and when to seek help. Some of us may embrace something like utilization management to improve the efficiency and appropriateness of test ordering. Some of us may redesign systems to enable providers to order an anemia workup instead of having to know the vagaries of MCH, TIBC, and ferritin. Some of us may decide to add audience-specific context to all of our communications to enable providers of all stripes to understand what we are saying, because context matters. I probably think about this more than most other people because our family has moved around a lot. My immediate family members were born in the US, England, South Africa, Rhodesia, Zambia, and Zimbabwe. Once we came to the US, we've lived in Maryland, Wisconsin, California, Florida, North Carolina, Virginia, Alabama, Massachusetts, Illinois, and Georgia. I like to think that living in so many parts of the US and overseas has helped inform our worldview. When some of my children were writing college applications, I suggested an opening line for their essays, a phrase that might resonate with the anticipated audience. Something like, I'm a blonde-haired, blue-eyed Jewish kid born in Birmingham, Alabama, to 2 African parents. Think about it. I hope they learn to stop and think about where people are coming from, and that these experiences have made them aware of cultural differences. It may be where you're from, it might be what you do, but measures of value are relative. In medicine, we find that both administrative colleagues and physician colleagues often do not understand what we do. And focused business entrepreneurs may have entirely different perspectives and ideas altogether. That is why it is important to be able to explain what it is that we are paid to do and why. So a little bit of advice. If a venture capitalist has an eye in your hospital or practice, it is only because they perceive inefficiency. Their logic is simple. Buy cheap, deconstruct, squeeze out the fat, reconstruct, and sell for more. And that's one very clear reason why you need to know what you get paid to do, and to explain very quickly why you are not part of the fat. So imagine this discussion. What am I going to pay you to do? Well, my job is to diagnose tumors. Okay? Well, why should I pay you instead of somebody else? Well, I'm the best. Well, how do you know that? Well, look where I was trained. The response is going to be, okay, that's where you were. Now tell me who you are. You still haven't told me why I need you. A business leader may not want someone whose only responsibility is to issue a certain number of reports every day. They may want someone to own all the problems related to specimen diagnosis, whatever they may be. We are being asked right now to diagnose, we're being asked right now to describe what our niche is in healthcare, what we bring that only we can contribute. And we cannot assume that everyone else knows. When the question is, what are you paid to do? The answer may be you are paid to think, to translate, and to protect patient safety across the institution. It may be that you are the interface between science and medicine, and we are the only physicians with a firm foot in both fields. It may be that you understand science and translate it to other physicians, providers, and administrators. The long arc of history shows everything becoming more quantitative and less qualitative, more digital and less analog, more integrated and less discrete. The diagnostic process is no exception. We can expect to analyze more aggregated and disparate information. We can anticipate deeper engagement, validation, reproducibility, precision, and quality measures. And the net effect will be greater efficiency, greater opportunities, and greater reliance upon pathology. I believe that we are in the early moments of the golden era of diagnostics, when treatments will be dictated by diagnostic outcome continually updated and refined. Our niche at the intersection of science and medicine will confer an unobstructed view of a promising future, and as always, it will be our task to interpret and explain what we find. I stand before you humbled by the patients who depend on us for an accurate diagnosis, excited for the scientific journey ahead, and committed to working with you, with all of you, over the next 2 years to make it happen. And I'm looking forward to it.